All right, team, welcome to Drug Detective's question and answer session. Get ready for this one. It's a hot topic in infectious diseases. We've got a 32-year-old man with a history of COPD who's not feeling too hot right now. Fever, chills, and coughing up a storm. And the plot thickens. He's been hospitalized before for his COPD and now has hospital-acquired pneumonia, or HAP for short. Cue the detective music. So, where do we start? Well, first things first. This isn't your run-of-the-mill community-acquired pneumonia CAP. We're talking about HAP, which means the bacteria causing it are likely more resistant. And guess what? The sputum cultures show gram-negative rods. That's a classic clue right there. Now, let's break down the options. A. Ceftriaxone. Okay, ceftriaxone is a great antibiotic for community-acquired pneumonia, but for hospital-acquired pneumonia, we need something stronger. HAP often involves tougher bugs, and ceftriaxone just doesn't have enough firepower to handle gram-negative organisms like Pseudomonas. Not our top choice here. B. Piperacillin/tazobactam. Ding, ding, ding. This combo packs a serious punch against gram-negative bacteria, including Pseudomonas, a usual suspect in CHAP. And since our guy has been hospitalized before and has COPD, he's at higher risk for resistant pathogens. Piperacillin/tazobactam gives us broad coverage and gets ahead of that risk. Looks like we've got a strong contender. C. Azithromycin. Azithromycin, great for community-acquired pneumonia, where atypicals like Mycoplasma might be the culprit. But here in the HAP zone, not so much. Azithromycin doesn't have the muscle we need for gram-negative rods. We need to bring in the big guns for this case. D. Amoxicillin/clavulanate. The old reliable combo of amoxicillin and clavulanate. It's a great choice for outpatient infections or mild cases, but for hospital-acquired pneumonia caused by resistant bugs, it's like bringing a pocket knife to a sword fight, just not enough power. So, friends, if you're still tempted to pick azithromycin or amoxicillin clavulanate here, you might want to rethink your strategy because this HAP case needs something heavy-duty. Piperacillin/tazobactam is like the SWAT team of antibiotics for these kinds of infections. It covers all the bases, gram-negatives, resistant bugs, and even our arch-nemesis, Pseudomonas aeruginosa. Now, why is this important? Hospital-acquired pneumonia is tricky business. It's one of those situations where empiric therapy, aka starting antibiotics before we have the final culture results, is key. We don't want to risk undertreating the infection while we wait for more clues. So we go broad and then we narrow it down later when we know exactly what we're dealing with. Piperacillin/tazobactam gives us that confidence it's got the range and it's safe for a patient like this with a complex history of COPD and hospitalization. So, what's our final answer? B. Piperacillin/tazobactam. It's broad spectrum and ready to take on those gram-negative rods, including Pseudomonas, which is exactly what we need in this hospital setting. And here's a little tip for your Naplex. Always keep an eye out for red flags like hospital-acquired or healthcare-associated infections. These terms are your clue that resistant pathogens could be at play, and they'll help you rule out less potent antibiotics like ceftriaxone or azithromycin. Remember, when it comes to infectious diseases, it's all about making sure you're matching the right drug to the right bug. And that, my friends, is how you win the battle against hospital-acquired pneumonia. So, keep those antibiotic guides handy, stay sharp, and always look for those key terms in your cases. And just like that, another case cracked by the drug detectives. Until next time, keep on solving one patient at a time. All right, detectives, we've got another case hot off the press. Today, we're dealing with a 58-year-old gentleman with a triple threat: hypertension, type 2 diabetes, and chronic kidney disease. Now his blood pressure is still too high at 152/88 millimeters of mercury, despite being on a solid dose of lisinopril. The question is, what's our next move? Let's break it down one clue at a time. A. Add hydrochlorothiazide. Thiazide diuretics are a go-to for hypertension, but they can lose effectiveness when kidney function drops. And with this patient's eGFR of 40, hydrochlorothiazide isn't going to pack the punch we need. It's like bringing a water pistol to a firefight. So this isn't our guy. B. Add amlodipine. Now, this one's looking pretty promising. Amlodipine is a calcium channel blocker, a class of drugs that works really well alongside ACE inhibitors like lisinopril. Not only does it help lower blood pressure, but it's also a great option for patients with chronic kidney disease. It's not dependent on kidney function for effectiveness, which is a big plus. Definitely worth a closer look. C. Increase lisinopril dose. Well, we'd love to do that if we could, but our patient's already on the maximum recommended dose of 40 milligrams daily. So, nope, no more room to move with lisinopril here. D. Add spironolactone. Spironolactone could be helpful in resistant hypertension, but we've got to be careful. This guy has CKD, and spironolactone can raise potassium levels, which is risky when kidney function is already compromised. So while it might be a good option later, right now it's a bit of a gamble. So what's our best option? If you've been keeping your detective instincts sharp, you've already figured it out. B. Add amlodipine. Why? Because in this patient who's already maxed out on lisinopril and has CKD, we need a med that's going to work effectively without relying too much on kidney function. Amlodipine fits the bill perfectly. It's going to lower his blood pressure, protect his kidneys, and play nicely with his ACE inhibitor. Now, let me guess what you're thinking. Why not hydrochlorothiazide or spironolactone? Well, here's the deal. Once that kidney function starts to dip, like in our patient with an eGFR of 40, hydrochlorothiazide just doesn't have the same oomph anymore. It's like trying to inflate a flat tire with a leaky pump. It's not going to cut it. And spironolactone? Sure. It can be great for resistant hypertension, but remember, it raises potassium levels. With CKD, our patient is already at risk for hyperkalemia, so we've got to be careful not to add to that risk too early. It's like playing with fire. When you've already got a spark going, save it for later if we need it. So we're going with amlodipine because it's the safe, effective, and smart choice. It's going to bring that blood pressure down, and it's not going to make his kidneys work any harder than they already are. Plus, it's super effective for patients with hypertension and diabetes, like our guy here. Here's a pro tip for your NAPLEX. When managing hypertension in patients with CKD, look for meds that won't depend too much on kidney function. ACE inhibitors and ARBs are great first-line options, but once they are maxed out, calcium channel blockers like amlodipine are often the next best step. It's all about giving your patient the best chance at control without causing harm. So, our final answer is B, add amlodipine. It's the perfect sidekick to lisinopril in this case. And just like that, another blood pressure mystery solved by the drug detectives. You're on your way to becoming pros at hypertension management. All right, detectives, here's our next case, straight from the clinic. Today, we've got a 22-year-old woman with moderate persistent asthma. She's been using her albuterol inhaler about 4 times a week and wakes up with asthma symptoms twice a month. Her current treatment, budesonide, an inhaled corticosteroid at 180 micrograms twice a day. The big question is she well controlled, or do we need to adjust her treatment? Let's break it down one clue at a time. A. Increase budesonide dose. Increasing the dose of her inhaled corticosteroid might seem tempting, but hold up. Her current regimen isn't doing too badly. She's only using albuterol 4 times a week and having mild nighttime symptoms twice a month. We might not need to push her into a higher dose just yet. B. Add montelukast. Montelukast is a leukotriene receptor antagonist that could help with control, but is generally used when patients have allergies or when inhaled treatments aren't quite enough. Based on her current symptoms, she's not at the point where we need to consider this. Not quite the perfect fit. C. Add formoterol to her current regimen. Now this one's interesting. Formoterol is a long-acting beta agonist, LIBA, that works well when paired with an inhaled corticosteroid like budesonide. It provides long-term control of asthma symptoms and reduces the need for rescue inhalers like albuterol. This could be the step we're looking for. D. Continue current therapy. Her asthma is somewhat controlled, but using a rescue inhaler 4 times a week and having nighttime symptoms twice a month means there's still room for improvement. So while her current therapy is doing an okay job, we can do better, Dr. Bosnack enthusiastically. So, detectives, what's the best option for our patient? You guessed it, C. Add formoterol to her current regimen. Why? Because she's already on a low-dose inhaled corticosteroid, and adding a LABA like formoterol gives her that extra layer of control. It's like having a solid team player come off the bench to keep her asthma at bay between doses. Formoterol will keep her airways open longer, reduce her reliance on albuterol, and help with those pesky nighttime symptoms. Now, why not increase her budesonide dose? Or stick with what she's got? Well, bumping up the budesonide could help, but it might also come with more side effects, especially since she's already doing relatively well. And continuing her current therapy, while not disastrous, isn't quite enough to call her asthma well controlled. She's still having symptoms regularly. And as detectives, we're aiming for the best possible outcome, not just okay. So, here's a key takeaway for your Naplex. When dealing with moderate persistent asthma, if a patient is on a low-dose inhaled corticosteroid and still having symptoms, the next logical step is to add a long-acting beta agonist, LABA, like formoterol. This combo gives them that extra stability without needing to jump to higher doses or different drug classes too quickly. It's like adding reinforcements to your asthma defense team. Remember, detectives, when managing asthma, we want to aim for no symptoms, no waking up at night, no albuterol 4 times a week. By adding a LABA to her regimen, we're getting her one step closer to that goal, and we're doing it safely and effectively. It's all about customizing the treatment plan for what the patient really needs. So, the final answer here is C. Add formoterol to her current regimen. This 1-2 punch of budesonide and formoterol is going to help her breathe easier, literally, and hopefully give her some peaceful, symptom-free nights. And just like that, another case cracked by the drug detectives. All right, detectives, stay curious, stay motivated, and remember, you've got the tools to tackle any challenge that comes your way. See you next time.